Hello and welcome to another episode on Viva Learning Center. Happy to be back for another webinar. My topic tonight is pretty much similar to the others. It's all based about implant dentistry. And as many of you know that have joined in on the past, I very much enjoy placing implants as a general practitioner in New York City. And I think that a lot of us have some difficulties in terms of trying to assess how we can actually implement implants into our office, how we can profit from them. Sometimes we do procedures and we end up having kind of a loss leader type of a thing just so we can do them. And I've actually gone into the supermarket on occasion and seen how they sell cereal on certain weeks for only $1 for a box of cereal. And I guess it's a good idea to draw people in to the supermarket, and you end up leaving with hundreds of dollars worth of material of food once you leave. But as a dental practice, we can't offer those things. We can't offer necessarily the free cleaning all the time and expect to get returns on those values. So I've had many encounters over the years with other doctors who have had struggles trying to profit from implants. And while you can be successful, you can actually lose money on certain cases. And we never really want to have that type of situation. We want to always be able to become profitable from what we can do, especially when we're having success. When we have failures, of course, we expect to lose money on failures. But when we have success, we hope that we are going to profit from that success. So I want to thank my sponsors tonight as well, IDS, Integrative Dental Systems. And also, I'd like to thank Trong from Viva Learning in helping us put together this yet another webinar. If you haven't seen some of the other webinars, I think this is going to be my 6th webinar in total. In addition, there are some podcasts and some clinical tips. You can see those on the Viva Learning webpage. A lot of the stuff that I'm going to speak about tonight, there are greater details in some of those other webinars, so I invite you to go and visit those at the Viva Learning webpage. So what is our goal with implant treatment? What are we trying to do? Is it to put a screw in the mouth? No, our patients come to us because they want teeth, and our goal is to try to give them teeth. And with implants, we're trying to recreate that natural dentition. So what the patient originally had, and if we can, we'd like to do better than what the patient originally had. If we can try to either preserve or enhance what they've had in the past. So what can we accomplish? Well, we can take situations like this. You can see in this area we have some overcrowding, and we can spread that out with some orthodontics and deliver the patient a nice functional tooth. Instead of just trying to just fit in a screw into this area or a fixture into this area, we're going to open it and go ahead and restore it. And in cases with severe periodontal attrition or lack of finding their toothbrush, we can go ahead and implement some major reconstruction in implant therapy, and we can give patients back their function. Well, I love this slide. This is from my mentor, Dr. Park, and it's just a wonderful slide. He did such a wonderful job trying to figure out which one is the implant on this slide is nearly impossible. Dr. Park is the CEO of Megagen Korea, and he is absolutely fabulous clinician in addition to being a CEO. And what I love about this slide is he took pride in recreating this natural dentition, and we can't tell which tooth was the actual tooth that was the implant, then we know that we've had that success. And going back again, you can see, look at that, how we can't really tell which tooth it is. Maybe it's a slightly lighter color. We can kind of darken that a little bit. Maybe nowadays with the zirconia custom abutments underneath, we can maybe darken that a little bit more. But it's really a beautiful job when we realize which tooth actually was extracted. So my question to you is, can you do this? If you're not already placing implants, can you do this? And the answer is a resounding yes. There is no reason why you cannot do this. This is something that any general practitioner, any specialist can perform. This is not rocket science. Can you do the most complex cases? Maybe not. Maybe that's not what you want to do. But can you handle some basic cases? Absolutely. But the key is to try to be able to be profitable in these procedures. So If we want to discuss with our patients which way to go, whether or not to go with a bridge or an implant, fixed prosthetic, obviously with one we have to prepare the teeth, whereas with implants, we have a different type of solution. Instead of preparing the teeth and having that cantilever tooth or that pontic site and having to floss thread underneath that area, we can go ahead and treat the tooth as an individual, place an implant with a healing cap, and eventually go ahead and load that implant with a crown, and the patient has now the ability to floss. So it's certainly not necessarily an issue as to whether or not they should have an implant. We all like implants. They work great. And when we have good bone available, or if we can regrow that bone, we can have great success. So if we have success, we want to be able to profit from that success. In trying to make this slide, I ran around asking a lot of different lab techs and some of my other dental friends how much things actually cost. While I don't always perform bridges, I haven't actually done a bridge in quite some time. But typically they range from around $2,000 to $5,000 US based off of a 3-tooth bridge, a 3-unit bridge. And the laboratory costs on average are about $150. I'm not talking about sending these off to some cheap foreign country that may be able to do it for $25 per unit. But on average, I would say about $150 US would be reasonable for each tooth. So having something like, let's say, $450 for a 3-unit bridge. When we discuss implants themselves, their costs can vary. And if you live in, let's say, the city of San Francisco or in Manhattan, New York, we can see implants with a post and a crown go as much as $6,500 per unit. That can be very expensive. In my office, we're somewhere around the neighborhood of around $5,000 for all of that. And our responsibilities as a dentist, as the person who is paying the bill for the components, we can have some various different varieties of costs. Implants can range from about $150 for a reasonably name brand implant. I'm not talking about these internet-based companies, but a reasonably brand implant should be about $150, and going up as high as $550 for some of the premium, ultra premium line, which I'm not sure that there's any better benefit than the $150 implant, but yet these implants do exist. These companies do exist. And the same could be said about stock abutments or custom abutments. They have a varying range from around there for what you see, $60 to $200, or $175 for a UCLA custom abutment to $350. And crowns, individual crowns, going back towards our original pricing, about $150, $200 for a regular crown that would go on top of it. And you can use a stock abutment and prep it and just take it as a regular base type crown and bridge impression, and to save a little bit of money. And of course, when we place implants, if we're extracting a tooth, we do want to preserve that bone. So figure around something like $50 to $125 for biomaterials to be able to do the extraction and graft. So our totals can be quite expensive. And if we're not careful, and if we're trying to offer a implant for, let's say, $1,500 to $2,000, we're going to be in trouble if we're placing one, let's say a Straumann implant for $550, an abutment from Straumann, which could be $350, and then going to a good laboratory and spending a lot of money on a crown. We may be in the point of losing money between our overhead and our assistants. We can be in big trouble if we're not careful and manage these things correctly. And I hate to treat dentistry as a business, but in the end, we do have to function as a business. We have to be able to pay our bills. My patients aren't going to say, well, give me a discount, and I have to tell them, well, I'm sorry, I don't have enough to pay my water bill this month, so I can't use water during our procedure today. So we need to be able to cover all our costs, and our employees need to get paid, and benefits, and all the things that come along with the business. So we do have to take these things into account. When we look at a bridge versus an implant in terms of chair time, I'm not so sure that an implant is faster or longer. Typically for an implant placement, I'm about 30 to 60 minutes for an implant placement. I've done some really fast ones and some that have taken a lot longer with some trouble. On a bridge, on FPD, something about 30 minutes to do an extraction, and let's say 45 minutes to prep and provisionalize. At a second visit, maybe 5-minute post-op. We don't really need a post-op for a bridge, but they may come back, let's say 4 weeks, a month later, and start taking an impression for a bridge. For an implant, depending on when it's ready, could be a few months. But roughly about 30 minutes to 45 for an impression, and an insert about the same. So we can roughly say that they're about the same length of time. In terms of starting up for a package of implants, they can vary in range of prices depending on the number of implants, but we do need to buy implants and have some inventory, and we do need to have a motor and a handpiece to be able to deliver the implant. So we do have to have some initial costs, and I like to place the AnyRidge implant, which is a little bit more of a premium implant. When I have a patient who wants a discount, I usually go to my other go-to, which is the Reflect system, which is available from IDS, Integrative Dental Systems. And I do use the either the Nobel or the Zimmer Reflect line in those cases where we're trying to save a little money, but I prefer to use the AnyRidge whenever possible. So when we're talking about the surgical supplies that come with placing implants, we do have a lot of biologics that we have to worry about. We do have to stock some bone grafting material, whether it be synthetic or allograft, or your choice, because we can't go harvesting bone for every single case that we want to do. So we do have to buy some surgical instrumentation as well. And then I left about $1,500 for some miscellaneous stuff you might want to buy. And some of the things I recommend, which are way more than $1,500 that go into that unlimited range, is something like a piezo unit or a cone beam. I have a cone beam for every single patient that I'm going to place an implant on. I also use radio frequency analysis from Ostel. PRF is a great addition. And these days, 3D technology is really amazing between the navigation, which you can see this Navident unit up here, 3D printing, the Formlabs you see here, intraoral scanning and milling units, and whether or not you're going to mill your own crowns in your office. In terms of surgical supplies and instruments, please check out the Viva Learning site for the Extraction Simplified lecture that I gave for seeing some of the new instruments. In addition, I've developed a surgical kit from TBS USA. It's available through a lot of the major dealers like Patterson and Burkhardt and Benko and all. But we did develop this surgical kit from TBS. Very proud of it. You can check it out. It has everything you need in one. But the Extraction Simplified talks about how to extract teeth and how to go ahead and debride those sites and prepare for implant placement. So let's talk about the history of dental implants. Well, in 1950s, Ingvar Brånemark, Pierre Ingvar Brånemark, may he rest in peace, actually was an orthopedic surgeon, and he was toying around with some fixating tools. What he did was he took these optical titanium chambers and he placed them into a rabbit's fibula. And he then went and followed and was trying to see the blood flow through a microscope to see what was going on. And then what happened, kind of accidentally, is that he noticed that he could not remove those optical fixtures. He was just trying to monitor what was going on inside the fibula. And what happened was he couldn't get out that optical chamber. And you can see the optical chamber here, trying to monitor, seeing what's going on and looking at the way that the bone heals inside, and they couldn't remove it. So he had realized that he had integrated into the bone, and thus the term osseointegration. So really amazing stuff that happens by accident, kind of like the penicillin vaccine. And if we think about, I'm sorry, not vaccine, but about penicillin, development of penicillin. And then Brånemark decided that he was going to place some implants on a dog, and you can see them placed here on a dog. And they waited about 3 to 4 months before they loaded them, and they saw that these titanium fixtures were able to be maintained for about 10 years. And that's pretty good, considering most dogs don't even live about that long. So that's pretty nice range of time. Hopefully we can get this longer than that out of our patients. We'd like to say that they last forever, but in this world, not necessarily everything lasts forever. In terms of expectations, we have to look at our patient and we have to be able to say, well, how can we help them? And it's great to understand what we can do for them. Some people may present with good jaws, as you can see here, and probably good amounts of bone volume, and others may have a lot of atrophy over time. So we need to understand how we can help them, especially patients that wear full dentures. They probably look like this when they remove their full denture. So over time, in about 1948, they developed different types of implant systems. One was a subperiosteal implant, which was basically built in. They used to open up the jaw and take an impression of the jaw itself, and then they would install, using some screws, a a framework, a Vitalium framework, titanium as well. And they had some success and some not success. Actually just removed one fairly recently that was almost about 30 years old, so it's pretty good. Today they are CAD-CAMing them, so they are back. They are back in a big way. Technology has been able to take us to that next level to where we can actually do these cases again. And you can see here's a CAD-CAM treated SLA surfaced, a titanium subperiosteal implant. Transosteal implants were next on the list. They came around in 1973. They had a good survival rate of about 95% after 5 years. And they were basically installed through the jaw underneath, going under the mandible itself and then fixated over the top. And as you can see, it's quite an invasive surgery. And then they'd have some cylinders that would stick out, which can attach to a denture. But endosseous implants are basically what we have been using for years. There was the blade implant that came out, which was basically installed by creating a cut into the bone and then placing the blade, and then they'd be loaded a little bit later. And then root form type implants for a cylinder, and then screw type implants were developed a little bit later on. And I think today we're mostly using these cylindrical endosseous root form implants that are screwed in. There are some implants like Bicon that are not screwed in that do have some great success, but for the most part we're using screw fixtures. And we always want to try to plan our goal in advance. As you can see here, somebody planned this case with not allowing to leave enough prosthetic space here. So we always want to try to have enough prosthetic space in mind. This case probably should have had some little bit of bone reduction before they went ahead and placed the fixtures into the mouth. We need to worry about our pre-op preparation. Then we can look into the surgical preparation and then the post-surgical management at the end. But to starting off with our pre-preparation, we always want to try to plan our implant, especially for a single tooth, from a prosthetically driven down philosophy. So we plan where that screw access hole should be, try to place the implant where that is, and if we need to augment the bone around it, then thus be it. That's what we would go ahead and do. In terms of depth, we always want to try to place a bone level implant about 3 to 4 millimeters deeper than the adjacent CEJ. So if I'm placing a central incisor, I would look over to that adjacent central incisor and hoping that the tissue is in good shape. And I want to create a little bit of an emergence profile. I want to have some running room. Too often we're seeing cases that are not placed at a good level. They're the equilevel with the adjacent tooth. They should be a little bit deeper for these root form type implants that are bone level. If it's a tissue level implant, that's a different story, and that's for another webinar. But for the most part, these days we're using bone level implants, and we can then develop that soft tissue if we have that 3 to 4 millimeters of running room to create that area, that space. Another little rule. Please pay attention to these rules because they may come important at the end of the webinar. But the interdistance space between two implants was discovered by Tarnow and Chu, and basically it was the same rule as for teeth themselves in terms of trying to create enough space for the tooth to be developed. So from edge to edge from one implant to the other, we want 3 millimeters. That's the number 3. 3 millimeters, if I can say that again, from Tarnow and Chu, 3 millimeters would be the ideal space that we'd want to have between two adjacent implants from the one edge to the other. And this again allows us to create enough of an emergence profile. So here we're having great success. This is going to look like a molar. This is going to look like a premolar because we have created enough space and we have enough ability for the blood supply and enough tissue to form around there to give us some nice emergence. Before we start any type of a procedure, if I'm going to build my house, I'm going to need blueprints. And the same goes for implants and basically anything we want to do. We would make a treatment plan. With implants, we do want to have some type of a blueprint that we can work off of. So is 2 dimensions enough to give us that blueprint? Is a panoramic x-ray, which can give us all these details, enough to give us that answer? And basically the answer is basically no. 2 dimensions is not enough, because if I look at Prince William here, it looks like he's giving the middle finger to the crowd. In 2D, if I have anything at the right angle, it can look a little bit differently, and that's the perception versus reality. But in 3D, and we do live in a 3-dimensional world, we could see that he was actually just giving 3 fingers. and giving the okay sign, or maybe it's 3 for dinner this evening. So ideally, we'd like to be able to have more than 2 dimensions in what we do. We want to be able to see things in 3 full dimensions. So there are 2 philosophies, 2 technologies that my partner and I, Dr. Gans, who helps me run the educational programs that we work together with, we find that there's 2 technologies that we need for implant placement. They are essential. We cannot do much without them, because we need to be able to plan the placement of the implant and the restoration. And we want to know when that restoration is ready, when we can go ahead and when the implant is ready for that restoration. So we need some type of a device instead of just waiting a estimated amount of time. And that's my partner, Dr. Scott Gans, at our educational programs. That one's in Mexico. You can feel free to come and join us at one of these programs. We have another program this December, and again, we have another 4 programs next year. Actually, there'll be a 5th program added very shortly. But you can come visit us in our facility. And, this one's in Mexico, where we can actually place the implants yourself. We help you over-the-shoulder training. Yes, use everything from beginner to advanced cases. We have all the materials you could think of, including navigation. You have Navident navigational devices there to be able for use. So one of the things we have there as well is this a CBCT, a cone beam. And in terms of trying to figure out where the anatomy is and where the implant should be placed, there's no better way to do that than using a computerized tomography imaging service, or having one in your office. Personally, I'm on my 3rd CBCT machine in 10 years, because there's always something great coming out. And actually, this is the newer one that I just got. This is basically becoming the standard of care to have this CBCT. But the newer units, such as this one from Carestream, are just absolutely incredible in terms of positioning the patient, trying to be able to get the accuracy of the shot. No longer do we have these lasers where we just line up the allotragus line. Now we're actually using cameras to position the patient. And then once we are reconstructed, there are some really nice, fancy technologies that have been created. One thing has been the removal of the beam hardening on the later units, with the removal of beam hardening, so we can actually see the implants very well. Another is the metal artifact reduction, which, as you see here, is MAR, metal artifact reduction. And you can see that little fracture that's visible when you hover over with the metal artifact reduction tool. So in looking to purchase CBCT, tried to get one with these new later technologies. It also has facial scanning, which is a nice little adjunct that we can actually plan the patient's cases in advance. And if you use an intraoral scanner and combine that, you can actually do a digital smile design in advance. So the technology is advancing extremely fast. The kids coming out of school understand this technology, and they're looking to use this technology to their advantage. And it's up to us to stay together with them and actually advance ourselves even further and push the envelope as far as we can, so that we can deliver the best ultimate restorations for our patients. So here's just a little example of a scan that I took in my office, and you can see when I turn the metal artifact reduction on and off, I mean, you can see what happens here. It's amazing how all that metal just goes away. So before I couldn't really see that bone. Now I can see the bone, and I can actually see an implant over here that's actually failing. I can see a healthy implant here and no bone loss. And then this implant, if you just take another look here, you can actually see radiolucency developing all around the implant itself. We have not osseointegration, but fibrous integration in this case. So it's a great tool to have in our office to be able to view that with that metal artifact reduction. If I don't have a metal artifact reduction tool, or I don't have a unit that can remove that beam hardening, it's pretty normal to see black around an implant. So it would be something where the CBCT kind of skips for a moment and loses its function. The beam hardens too much, and we end up seeing radiolucencies. That's called beam hardening. These CBCTs now remove that, so now we can actually see when an implant is actually successful or failing. In terms of radiation, I think I've posted this once before, but a CBCT exam is not very high. The green machines are very, very low, about 40 microsieverts. And if you think about it, water drinking per year is about 50 microsieverts. So we can use these with the right amount of discretion when we need them. Certainly a pre-op, and when necessary, a post-op CBCT. And I'm very comfortable taking them on my patients without really worrying about it. Once we have that CBCT, we can check out the triangle of bone to try to figure out where we can place that implant. And please check out Dr. Scott Gann's Viva Learning series. He has a couple of webinars in which he does discuss that. And one of the things he discusses in there is where to place the implant within that triangle of bone, when we have to be using different types of either one-piece or two-piece implants, or if we need an angled abutment. And we can see all this with that CBCT. Once we have taken the CBCT, we can look at that slice and try to evaluate what is the right type of an implant to be placed so that we can have more success in all of our cases. So here's a case of a young gentleman who came to my office from California, and he was already missing a upper molar. And you can see here that this area is very tight, that there's not a lot of room. So many clinicians may decide just to place an implant. And he had come to me as a referral, and he had some issues. He needed some scaling root planing. He had some caries that we had to take care of. Also, he needed orthodontics and then implants, an implant. And if we add that up, it's about 9 months or so worth of time from start to finish. But because we're using more sophisticated technology, we are able to kind of speed that up. So when we take our scan, we can see that he does have a good volume of bone. He has about 11 by 11 millimeters worth of bone before the sinus cavity. So we can go ahead and place an implant. But if we place it too early before the orthodontic treatment, we're going to end up with a food trap. So we want to wait a little bit of time, and we want to make that space so we can place a crown. So we went ahead and we did the ortho. We did some expansion to get the tooth into the right position. And then we went ahead and we placed an implant. And you can see here is the implant placed. We did a tissue punch placement, which this was done about 8 years ago. Today, I would definitely not do it that way. I would prefer to make a flap and try to increase the keratinized tissue by rolling that flap. And that's one of the reasons I like to show you this, is because there is still a depression here. So when we place these implants, try to do something that can be long-term successful by rolling the flap over. And you can see here is we've taken measurement when we placed the implant, and we got an 82 on our RFA Ostel device. So we know that that's a very good number. And we can try to employ our 6 to 8 week loading protocol when we do that, using this AnyRidge implant that we placed. And so we went ahead and at 6 weeks, we took another reading, and we can see we got an 84. And thankfully, the AnyRidge implant has a very nice emergence profile. So I was able to cheat a little bit and push that tissue just a little bit using the healing collar, and then finally push it a little bit more with that final crown. But using this sophisticated RFA or radio frequency analysis device, we're able to now load just after a few short weeks. So please check out some of the other webinars that we've done to learn more about RFA or ISQ. And here's his final post-ops that when he left our office. And you can see his actual treatment time was just about 5.5 months, because we didn't wait until the end of treatment. At about 6 weeks before his braces were off is when we decided to place the implant. As soon as the braces came off, we took our impression and went ahead and fabricated the crown, which took about 10 days to make. So our actual length of treatment time was just about 5.5 months. So it's pretty good in terms of handling all of that time. And that's a good thing to make us more profitable. Because if we can do things a little bit faster, then we can be a little bit more profitable. And as 3-year follow-up, before he went home to California, everything was looking quite well. In terms of trying to become even better at what we do and to become even more profitable, we have to employ the digital workflow. I invite you to check out Dr. Scott Gann's and Dr. Marco Rinaldi's book. This one's in Chinese. I prefer the Mandarin version a little bit better. But in there, they discuss how to go about and go through the step-by-step into be able to creating a surgical guide, or at least trying to plan your data. And one of the things that they're going to recommend, obviously, is to have a CBCT. And another thing that they may ask is to have the STL, either a cast of the uh, actual jaw that we're going to be implanting, or we're going to go ahead and take an intraoral scan using something like a 3Shape device or a Carestream unit or Medit scanner. We do have a question which I would like to answer from Angela, asking what is the difference in accuracy of RFA versus traditional torque testing of the implant, and has there been any studies showing that RFA is accurate and does not lead to premature failure due to premature loading? Angela, please do refer to some of the other Viva webinars that we've given, but I think this is a very important question. So RFA, there are roughly over 1,000 papers using RFA technology thus far in the literature that is on PubMed. And there's way more than that if you don't count the PubMed. So absolutely that there are lots of studies on them. There are definitely not going to be premature failure due to that. There can be premature failure due to torque testing. If we go too early and try to reverse torque an implant out of its osteotomy site, then certainly we can have an issue. But if we do not, if we are trying to just check with the ISQ, we're only removing a healing cap and then placing a SmartPeg driver, which is roughly about 5 newtons worth of force. So we're not putting a lot of force and reversing out that implant. So certainly having a ISQ device is an invaluable tool to me because it's the most objective way to be able to measure it, and it's the least invasive way compared to some of the other methods such as reverse torque testing. So getting back to our digital workflow, we would take our CBCT within our STL, and then we can actually go ahead and even fabricate a restoration if and when we want to have a temporary prosthesis prefabricated for our procedure. And merging the data sets is quite interesting, how we take these cast models and we go ahead and then superimpose them onto the CBCT, and we can then go ahead and plan our cases. This is using a free software such as Blue Sky Bio. Please do check that out. It's a free download, and we can even print out surgical guides for as little as like $20, even less in some cases. So going and learning about these technologies online is invaluable to being able to keep ourselves profitable instead of having to use, let's say, a third-party company. Personally, I'm a lot lazier, and I use the third-party companies and pay a little bit more. I do know how to do these other surgical guides, but running a very busy practice and having 4 children, it's quite taxing, and so I choose to go the third-party route. So a case like this where I had to extract these 2 teeth, I did grind these teeth, actually cut off the crowns and ground them and place them as a graft, and came back about 3 months later. And I look and I see that I have good, healthy bone. I'm a little bit short before the maxillary sinus, only have about 6 millimeters before the maxillary sinus. So I'm going to go ahead and do a sinus lift at the same time that I'm going to place an implant. In the past, I may have done this with an osteotome, but now we are using some more sophisticated devices such as the Densiburs from Versa. And we're going to do this guided. We helped to develop this type of guide. We call it a C-guide. This is one of the first versions that we ever made. And after we made a flap, we used these stoppers and we reversed drilled. After 1 pilot drill and forward, we reverse drilled and helped to push that bone more apical. So we can actually move up to about 2 to 3 millimeters of bone into the sinus if we have at least 5 millimeters of bone. In this case, I wanted to lift it even more. So I decided that I was going to use some bone addition into the osteotomy site. In this case, I'm using NovaBone. It comes in a syringe. I very much like this. I've been using this for about 4 years now. And it's really, really easy to go ahead and lift this up, and helps to push the Schneiderian membrane at the same time because you have this hydraulic effect as it is being placed through a composite gun. Then we go ahead and deliver the implant through the guides. We have a different guide here, and this is an R2 surgical guide, so we can get the implant into the exact position. We can even stop at the exact hex position. Once you see these little green lines as they show through in this little window, so the black line and the green line are evening out, so we are able to place them into the correct site, correct side, excuse me, so we can get our hex position to that buccal aspect. And again, you can see on this other implant here, we'll get it down to the black line, and then we'll turn it just a little bit more and get that green coming through the window on the buccal surface. And once we have that in place, You can see here, the green line is right through. Then we'll then take our RFA device and we will measure our osteotomy. Now, we did make temporary crowns, but our ISQs are not high enough. Even though our torque was good, our ISQs were not high enough, so we decided to do a delayed loading in this case. But we did lift the sinus and place 2 implants at the same time. On our CBCT evaluation, we can see that we did lift the sinus quite nicely in both these implants here and here. After a few months' time of healing, this was about 2.5 months healing, we came back and we took our ISQs again. As you can see, they increased. And now, instead of being 70s, low 70s and 60s, we now have mid 70s and high 70s for our ISQ. So we decided to place scan bodies in place after waiting a couple of weeks for healing. And then we took an intraoral scan and we were able to send this over to the laboratory so we can then go ahead and fabricate our final crowns. And you can see our final crowns on 3D printed models. And you can see how very nicely the screw access hole is right in the middle, because we were able to plan this using the CBCT and combining that with our casts or intraoral scans, putting that all together to be able to give us the ultimate type of restorative solution. As you can see, a few years later, we still have, he has an implant on the other side, so we did a post-op CBCT and another sinus lift. You can see how nicely the sinus floor is now behaving. But if we look at this case and we think about being profitable from this case, you can see here that 2 implants, about $1,800 each in our office, 2 sinus lifts, $1,000 each, for a total of 45 minutes. And let's say that surgical guide cost me, let's just throw it out there, let's say $300. So let's say a couple of implants, maybe $250 each, so $500. So our cost for that procedure was, let's say, somewhere under about $800 for that procedure, but we had a $5,600 fee, and maybe there's some ancillary products. So even let's say it's $1,500. So if I'm going to have to, something's going to cost me $1,500 and I'm going to make $5,600 during that 45 minutes, I'm going to be very happy to do that every 45 minutes of my day. And then going ahead and doing the implant restoration side of things, 2 screw-retained crowns, totaling about $2,500 each, total of 45 minutes chair time, about $5,000. My costs are not more than, let's say, $500 per crown. So it's, let's say, $1,000 worth of cost. So we're making about $4,000 worth of profit. So our total is $10,000, $10,600 for roughly about an hour and a half's worth of work, with our costs being somewhere in the neighborhood of, let's say, $2,000 to let's say even say $2,500. So it's about $8,000 worth of profit in just about an hour and a half's worth of chair time. So we can do a lot if we do things and we move things into the right direction by combining some procedures to become more profitable and still having that same amount of success. So just adding little techniques like this to our armamentarium can help us go a long way. Let's take another case. So this patient presented as a referral from a good friend of mine from Boston, and his patient lived in New Jersey and didn't want to drive too far to Boston. So he asked me if I can take a look at this case, and there would need some bone grafting. And you can see that these centrals are not in the best shape in the world. You can see that there's a lot of recession, and this actually has some severe mobility. So we need to go ahead and look at this on a 3D type of a scale, but we decided to take an intraoral scan of the mouth so we can go ahead and fabricate everything in advance and be able to make, let's say, a surgical guide if we wanted to. Once we went ahead and evaluated the case, we saw that there wasn't enough bone to be able to place implants simultaneously. So you can see from the CBCT slicing here, this is about what bone would remain. And this is where the tooth is just sitting. This is kind of what Scott Gantz likes to call air integration. This thing is just hanging out there in space by Sharpie's fibers. So we're going to have to regenerate this area. And the other area is not much better. The other central, you can see some radiolucencies here and a very, very, very thin buccal plate. But we can probably maintain this if we manage to extract the tooth atraumatically, which is what we're going to aim for. So you can see extractions were uneventful. We raised a flap and we wanted to regenerate this first. We're using our TBS serrated curettes, yay TBS, and we're using some Meisinger burrs, Strauss burrs to debride. We're doing a mucoperiosity release, and I'm using some lamina bone. And we're going to go ahead and lock in this membrane using some screws, tacks, excuse me. And we are going to pack some bone in there. You're combining using some PRF, building up and suturing over with some PTFE, making sure that there's no tension. So this is a classic GBR case, and you can see step by step how there's not that much bone, and we're rebuilding that bone. And when I look at this case, I said, oh man, you know, I really should have either used a larger membrane and try to build this out just a little bit more, because the membrane is going to shrink. So really, I should have built it out just a little bit more. But luckily, I have enough tools in my bag that I can go ahead and try to expand that bone that's already been grafted. So when we look, we waited about 4.5 months for this case. When we look and we see what we've gotten from here to here, we can see that we were able to grow enough bone to be able to place an implant. So in terms of trying to restore this case, we went ahead and did a surgical guide so we can place the implants in the ideal position. And also I want to remove those tacks. So I had two little areas left over so I can remove the tacks. You can see these little pinholes over here. So after using our two guides, we're then going to use these denser burrs in reverse, and we're going to expand on that bone that should have been grafted just a little bit more. So we're using these denser burrs in a pumping action to try to expand it. I invite you to check out the Versa or Osseo Densification Academy, the OD Academy. And we're going to go ahead and place the implants in the correct position, trying to get the hex into that correct position. For temporaries during this case, as Brittany asked, we did use a Snap-on Smile type of device, or you can use an Essex device. Definitely do not want to use flippers for this type of a case. Good question, Brittany. Here we are using our ISQ device, placing our healing caps on. We did not want to immediately load this case because we were doing some expansion. And then we mark those little spots where the tacks were so we can remove them. They don't have to be removed, but I like to remove them, especially when the patient lives far away. And so we know exactly where those tacks are without having to raise a flap, or not a big flap at least, and we remove these two tacks. So nice little tools in our surgical guide when we want to use them. So here's our pre-op and here's our post-op. We definitely have more than 2 millimeters of bone, which is what we would need around that implant. So we're very happy there. There are special guide sleeves for denser burrs. Dr. Scott, thank you for asking. And can you buy them? You can buy them. These stops are not for sale. The ones that you just saw over there, I developed them myself, but there are G stops and there are the new guided stops from the Versa website, which you can go check out the new kit, which we helped design, which is a really, really, really nice kit. Please go ahead and check them out. And someone's asking, why can't we use a flipper in this case? Very good question, Kyung. The answer is because if we put pressure on that tissue and the bone, we are probably going to lose a lot of that buccal bone volume. So I try not to use that. I would prefer something that is not load bearing, such as an Essex appliance. It's a little bit easier on the soft tissue. Patient can smile, obviously can't eat with it, but I'm not a fan of putting a flipper in there. Whenever I can avoid it, I try to avoid the flipper or the partial type of a device. If you can do some type of an ovate and have some metal housing behind in this type of a case, you can, but I would prefer to leave this tissue and allow it to heal naturally like it did here. And you can see how nicely it did heal. Our ISQs went up even higher. We're now in the mid 70s and low 80s. So we're doing quite well. And now it's time to go ahead and restore this type of case. So we intraorally scanned the case, and we went ahead and fabricated the final crowns, as you can see here, with a long-term follow-up. Am I worried about emergence profile while using the Snap-on Smile? I choose to use the Ovate Pontics, Rosalind, on the Snap-on Smile. So I always keep my margins a little bit short on the adjacent teeth. So I always ask that in those types of prosthetics. That's temporary prosthetics. So I cut them down a little bit. You will see a little bit of the teeth on the adjacent teeth in those cases, but it's well worth it so that you don't put pressure on that soft tissue. Excellent questions, guys. Talking about these types of fees from here. So we did 2 implants at GBR, $900 each. Total of 45 minutes for that case costs about $5,400. So our profits were very high again, something that we can do very well and very predictably. the final crowns, again, totaling about $5,000, about a total of $10,400 for roughly about an hour and 3/4 chair time. And think about that, guys. Our costs are not more than $2,000 for a case like this, and we're generating something like, again, $8,000 worth of profit. That's something that we can be very happy with on a general basis, roughing about $4,000 an hour. And those are, guys, those are like high price CEO lawyers fees per hour. So either become a high price CEO lawyer type of a professional, or when you become a dentist, try to be more profitable by doing cases like that. Here's a delayed approach. I'm sorry that this got cut off. I didn't notice that before we transferred this over. But this is a delayed approach in terms of being able to restore this edentulous mandible. So in this case, in our pre-op planning, we can see we have a little sharp edge of bone, which we're going to file down. But in our planning, we're going to plan where to place the implants. We did take a scan of the patient's existing denture. We planned 6 implants, trying to avoid the inferior alveolar canal. In addition, we are trying to plan some bone reduction type of a case. So here we are planning the access holes for our final prosthetic. And in this case, we're trying to do a fixed type of a case. So we're going to take them out of the denture and into a final prosthetic. So I'll show you some little brief moments of the surgery. So we're going to create a flap and then go, as they say, ear to ear, full smile on this case, so that we can release enough to be able to load our surgical guide. So our first guide is going to be a bone reduction template, which we're going to fixate on. So we always like to do lingual ties here, or palatal ties if we're working on the maxilla. And we basically install this surgical guide using these drill and some pins to hold down that surgical guide. This case was done about 8 years ago. I'm now using slightly different type of guide. I'll show you in a moment. We then plan some bone reduction in this type of a case to make it nice and flat so we can place our implants into a good area of bone. We install a osteotomy guide, and then we start to do our drilling protocol to open up our osteotomy. Bonnie asks, do I use collared implants versus conical connection implants when using 2 to 3 implants with locators? Bonnie, I don't do a lot of locator cases, but I do like to still use conical connected implants in all cases, in locators cases especially, because then you get to engage that conical seal instead of having a non-conical implant, which that locator might not engage correctly. Here we are placing the implants in place. We're placing these without going through the surgical guide, so we can see that they're at the bone level. If I was loading this case the same day, I would have to place it through the osteotomy guide itself. But since we're not loading it, we can be able to see what we're doing, so I'm taking it off. And that's why I'm using a newer type of surgical guide these days that I could actually see through, which I'll show you in the next video. So that's visit number 1. We then close that up. Visit number 2 is an exposure visit where we placed our healing caps on. So that took a little bit more time, another visit. We did a soft reline at that visit so that we do not injure the tissue, so we can allow it to mature. And you can see what it looks like here. We get some nice, good, soft tissue healing. I'm going to try to move a little faster as I don't want to run out of time. You can see then we're taking an implant level impression. We're splinting together these implants so we can see where we're at. We then decide to go with a multi-unit and not go directly to the implant, so that added another visit. We then took a bite registration, that's a 5th visit. Resin verification, which we go ahead and lute together that verification jig using a GC pattern resin. So here's another visit, which is the 6th visit, verifying on the x-ray that we are seated correctly. Then go to a printed try-in, and sure enough, it didn't fit. And so we had to section it and add a little bar here and some composite so that we can ensure that it's connected. Took a wash impression underneath to capture the soft tissue. You can see here's the x-ray showing everything seated with that little bar. And then went ahead to our final visit, finally, after all these visits, to go ahead and insert our final structure. And you can see here we made a nice screw-retained structure. Scott Gans, stop trying to make me laugh. Thank you very much. So here we are on our insertion. And you can see that we're going to go ahead and get a good bite here. And then we end up treating the upper jaw later on. But we did do nice work here on 6 implants, something that Scott Gans can be proud of in terms of parallelism. So in this delayed approach, how profitable actually were we? We had a surgical visit, exposure, impression of the MUA. We put new MUAs, which added another visit. We had to take a bite registration and try-in verification. We had to do that actually 2 more times because the printed try-in was wrong. And then we finally inserted. So it took me about 10 visits, but roughly it should take about 8 visits. So this is not so profitable for, let's say, charging $25,000 for an arch like this. That's not going to be very profitable. I just showed you some cases where I was making $8,000 for only a couple hours worth of work. Now I'm showing you $25,000 for something that might be taking me down to where I'm only, let's say, profiting about, let's say, $1,000 an hour, which is still not bad, guys. I'm not saying that that's bad, but how can you actually do that? So in these cases, how can we be able to go ahead and treat these? So what about a case like this where there's really bad teeth here? Can we do something that would be a little bit faster? You can see this patient just never really found his toothbrush. So going through it, as Dr. Scott Gans likes to say, it's not the scan, it's the plan. We're going to plan these cases out in advance. We're going to go through our surgical planning for both the maxilla and mandible so we know where everything's going to end up. And we are going to be able to look at the CDVCT slicing and plan accordingly. So we can know exactly where we're going to push these implants into their right position, whether in the mandible and in the maxilla. And then we're going to go through these cases, and please go check out the Viva webinar. The last one that Dr. Scott Gans did was actually about doing one of these chrome guided cases, or check out our Dentistry Today article, which came out in September, about how to do these types of guided cases. But you can see here how we're using the teeth to hold on a template, and we're fixating the pins in the same manner that we did with the other case. And once that's removed, we can then go ahead and extract the teeth. We're using our Frings forceps from TBS. Go TBS. Very happy with TBS and their amazing instrumentation. And we can do some bone reduction in these types of cases. Nowadays, I'm trying to do these in a natural fashion. We actually call this Chrome Natural. You can check out the Rodental website for their, or the Guided Smile website from Rodental to see that our these types of natural cases. And so we have our bone reduction template. We've reduced the bone enough, and we're using guides now that we can actually look into, and we can see what we're doing. So we don't have to worry about the drill being in the wrong spot or the implant not going to the right position. So we can go ahead and place the implants through the guide as well, taking them down to the bone level and seeing what we can do. We can see that implant's not down enough. We can see if it's in the right position, how much bone we have remaining. So it's a wonderful thing to be able to go ahead and do that. And then the beauty of this type of a guide is we can go ahead and place our multi-unit abutments and temporary cylinders at the same visit, and then go ahead and place our temporaries on the same day. So now we've just gone to temporization phase. So we've taken about 3 visits, 4 visits, and actually maybe even more, and put it into one visit. So these are really great. You can see how we get some nice uneventful healing, some beautiful soft tissue. You can see our post-op x-ray, good positioning. And then this is the kicker. How are we going to restore this? And instead of doing all those different impressions, which took so long for me to do all that, we've come up with a great device called an iJig in conjunction with Rodental. We can scan our temporary appliance, or you can do a flasking technique with some impression material, which I can go online and read about flasking. But this is a great way to be able to make a verification jig in advance. So we can scan it in the mouth as well to capture the bite, and we can ask for these changes that we may want. And then we can go ahead and then plan everything in different softwares, whether it be exocad or 3Shape. But we get back a section device, which we've modified, no longer has these flanges anymore, but this is one of the originals. And you can see here how we can go ahead and take this directly into the mouth, seat it on those multi-unit abutments, and fixate it into place. And this has a little plastic template on it, as you can see. And we're torquing it in using my favorite electronic torque driver. from Megagen called the MegTorque. And we're just torquing these in about 10 newtons worth of force. And then we'll take off this little sleeve, and we will lute this together. Take off the sleeve, and we will go ahead and lute this together. That's on the next slide. And we can lute it together either with composite, or you can use a GC pattern resin. And then we are going to scan, light cure that, and we're going to capture the bite as well. But we're also going to flow some impression material under the intaglio surface here, both palatal, lingual, and buccal, so we can pick up the soft tissue. These days, we've combined it with intraoral scanning of the soft tissue. So we're doing an actual intraoral soft tissue scan, so we can see that as well. It's a really, really nice device. And then we capture that with the bite, and this is what we send off to the lab to try to finish off our case. And then they go into 3Shape or exocad, and they can make for us a beautiful printed try-in, which we can try in the mouth, and you can take a look. Look at that fit of our printed try-in. Really, really nice. Any changes we want to make, like close that little diastema, we can do it in composite that minute. Send it back to the lab and go ahead and finish up our case. So here's our printed try-in verification, making sure everything's seated correctly. And then we get our finals back. So that's it, guys, 3 visits, and we got our finals back. And then we plaque that with some Teflon and some Teleo or some, whatever your choice of material may be. And here's what our finals look like. Really nice delivery, great bite, exactly what we had asked for. And these days I'm shying away from zirconia. I'm using nano ultra Trilor with a nano ceramic type of material on top of it. They really look beautiful, and they're nice because they wear against each other a little bit, whereas zirconia doesn't like to wear. These have a little bit of give to them, a little bit of wear. So we can always protect our patients in addition by delivering them these type of appliances. You can see the post-op final of the Nano Ultra Trilor, but also I'm delivering a mini comfort guard or a night guard so they don't break our prosthetics. We always want to try to be able to keep them, and we can change their lives one smile at a time. So this iJig is really, really amazing device, which we scan the existing appliance, send it to the lab, get back the iJig, lute it, pick it up, send it back, get a printed try-in, and go ahead and get our finals. So we can reduce this to just 3 visits and become much more profitable. So that same $25,000, instead of being 9 visits or 10 visits, we can reduce down to just as little as 3, even 4 visits. So really nice device. Please check out our new article that came out in September of the full arch surgical restorative for the Chrome, and the iJig one is coming out in January in Dentistry Today, which Dr. Scott Gans and I wrote together. So please check that out when it comes out in January. So what are our benefits? What we've learned tonight: diagnosis and CBCT intraoral scanning. Great way to go. We want this restorative-driven treatment planning. We need to be able to communicate in this universal language through that guided surgery. Really, really great stuff, being able to communicate to your laboratory, improve surgical and restorative accuracy using these guides, giving us more ability for success and being faster at what we do. And we can avoid many complications, which can make us more profitable. So some people ask, well, don't guides cost a lot? Well, do it in a free software like R2Gate or Blue Sky Bio, and then print it out on a printer. It's going to cost you about $25 to print a guide out. It's really not bad. If you want to use third party, which I do most often, or I call Scott Gans and make him make me a guide, either one can work out very well. And when applicable, try to use this ISQ device so you can see when your implants are ready and if you should be loading the same day. Such an invaluable tool from Austell, a really, really wonderful device. So in terms of starting, we have about 10 steps to go from beginning to the end, whether we're a beginner and trying to get from one level to the other. So getting from one step to another can take a lot of time. Some can get to the end very quickly. Others will take a little bit more time, but we can become good at what we do going step by step. Never try to just jump to the top step. We want to go one step at a time so we can get from one to the other appropriately and do things correctly in the right way. So I always like to end off with some funny stuff, and then if there's time, I'll answer some more questions. I have no idea how this implant got squeezed in from there and why on earth they decide to place an implant on top of another implant. But it reminds me of this very, very, very funny video, which I once saw. And I think this is exactly what was going on through that dentist's mind that day. Ow, that does not look pretty. Neither does that little truck there. So try to do things step by step. This pilot was certainly going step by step, or bounce by bounce by bounce by bounce by bounce by bounce. I hope the passengers on that plane were wearing whiplash neck braces. Not a very pretty sight. Teamwork is the ability to work together towards a common vision, the ability to direct individual accomplishments towards organizational objectives. It's the fuel that allows the common people to attain uncommon results, said Andrew Carnegie. And I think that's very, very, very true. Combining with our laboratory and our team and our office staff to become the best that we can be at all times, to give our patients what they deserve, which is the best. So going in that teamwork type of spirit. Even on a moving walkway, we can have some good teamwork getting by. So I want to thank you for your attention. I'm going to answer some questions now, but you can see that's my email over here if you need to reach me at iketowel@mac.com, and please visit www.aiedental.com. I do want to answer a couple of more questions here. Someone asked, there were happy cases with good bone. What about those cases with narrow bone and ridges? You can feel free to email me. I'd be happy to show you some cases where we do some bone augmentation simultaneously with those types of cases. What brand of implants are the best to use? Paras, all implants work very well. Try to use the ones that work best in your hands. I've been using a lot of the AnyRidge and the ReflectLine implants. I'm very, very happy with them. Rosalind asked, do you have your own ceramist, or do I use commercial labs? I do use commercial labs. I use Rodental Laboratory. I use some other labs as well, but I do also use Technique Porcelain Studio in New York. There's a lot of great labs out there. Find a good lab that you can feel comfortable with and stick with them. And if you're not happy, then you should be switching those labs. Again, I want to thank everyone. I want to thank you, Trung, again, for helping me put this together. You guys have been great, and I look forward to seeing you on the next Viva Learning website. Thanks, guys. Have a great, great Thanksgiving. Merry Christmas. Happy New Year's to all of those who are celebrating, and the best to all of you all over the world.